today we have a very, very special guest speaker, Dr. Jessica Caraway. And it's so very special because she's one of the former residents that she just finished her fellowship in interventional radiology with special interest in pediatric interventional radiology, and is at the VA, but with privilege here, and is the interventional radiologist for peds that we have in the community. You know, we are very proud and happy that she's with us, and looking forward to her presentation and her work to come.
Yes.
Okay, Jessica?
Welcome home.
Thank you. Very glad to be back. Can you all hear me? Okay. So today I just wanted to give you an overview of pediatric interventional radiology, just to get everybody together, let you know that I'm here, and kind of show you what we can offer, to your patients. So here are our learning objectives, because we are a CME accredited conference. So a little bit about me. This is my favorite child here. It's my little 2-year-old. Like Dr. D said, I went to med school here, did my residency here, and I went to UAB to do my fellowship. They have a giant pediatric hospital that's associated with UAB. And very few people want to do pediatric interventional radiology. So I got to spend as much time as I wanted to over there. I got some great training at that place. And this is my favorite little saying: interventional radiology is like surgery, only magic. I have a t-shirt that says it. So my favorite pediatric intervention is sclerotherapy for treatment of vascular malformations, vascular anomalies. There's a lot of confusion amongst people about vascular anomalies, exactly what can be treated, what they are. And so that's the first thing I wanted to talk about was, how to tell the difference and kind of show you what we can do to treat these lesions. So there is a whole group that gets together every 2 years, the ISSVA. Their most recent classification of vascular anomalies was in 2014. They all get together. They go to awesome places if you ever want to join this group. The last was in Melbourne, Australia, and the next one in 2016 is in London, if anybody's interested. So vascular anomalies are broken down into these two broad categories. You have your vascular tumors, and then you have your vascular malformations. There are benign, borderline, and malignant vascular tumors. Your benign tumors are your hemangiomas, your tufted angiomas. Locally aggressive or borderline are what you think of as your hemangioendotheliomas and Kaposi sarcoma. And then malignant, of course, is an angiosarcoma or an epithelioid hemangioendothelioma. There are more of these than I can name in this lecture today, so we're going to go over the most common ones, the ones that you'll see, and the ones that we can treat. So first, our benign vascular tumors. We have an infantile hemangioma, and as you can see, this is what you would see on the skin. If you did an MR, these are your sequences that you would see. They're T2 bright. And this is your infantile hemangioma here. They are the most common tumors. They're not usually present at birth, and these are the ones that grow rapidly over the first 6 months of life. They begin to involute, and then they'll resolve completely, usually by 9 to 10 years old. And so they don't need any intervention by us. If it's big, it's in the way of vision, or if it's causing problems with breathing, they could be surgically intervened upon. So this is your congenital hemangioma. A lot of people have a hard time differentiating between infantile and congenital. They get lumped into this big group of hemangiomas most of the time. So these are the ones that are present and fully developed at birth. Some will involute over the first year of life, and others will remain and need intervention. So this is what one looks like. And then this is an ultrasound picture of a hemangioma with some cystic spaces and kind of a disorganized arterial and venous pattern that you can see with color Doppler. This is a tufted angioma. I just threw it in because I've heard of it before, and it can be associated with that Kasabach-Merritt phenomenon, which is a consumptive coagulopathy, which can be very dangerous. These are uncommon, uncommon but not rare. So the only locally aggressive tumor I wanted to talk about was a caposiform hemangioendothelioma. This is a picture of one here involving the ear. This is a vascular tumor that involves multiple tissue planes, as you can see on this image here. It kind of starts at the outside and works its way in. This is generally associated with the Kasabach-Merritt phenomenon. And of note, it has a mortality rate of 24%. So because of the consumptive coagulopathy. So then we'll jump into the vascular malformations. This is where I come in. This is lesions that I can treat. You have your simple form, and these are your capillary malformations, lymphatic, venous, arteriovenous malformations, and arteriovenous fistula. And then you can have a combined malformation, where you can have any of these or all of them together in one lesion. And you see that a lot more than you would think. So simple vascular malformations first. This is a capillary malformation. So it grows in proportion with the child. This is the port wine stain that we learn about in radiology, and can be associated with Sturge Webber Syndrome. These are not generally treated by interventional radiologists. I've seen them get angiograms to try and map it out and see if there's anything that we can do, but generally there's not a whole lot that we can offer. Now this is what we do a lot of. This is a lymphatic malformation. It's synonymous with a cystic hygroma or a lymphangioma. They can be microcystic or macrocystic, and they can be micro and macrocystic. That's generally what you see. What you want to see as an interventional radiologist is one big cyst that you can, access and then treat. Those are the easiest, but unfortunately, it doesn't always happen that way. So the microcystic are more difficult to treat than the macro. But so this is they tend to happen a lot on the face that I've seen, and so here's this little girl's, and then on this MR you can see this fluid level of the lymphatic fluid layering in your large lymphatic malformation here. The venous malformation is the most common vascular malformation, and this is what you hear of the cavernous hemangioma. There's usually not a whole lot that you see on the skin. The mom will usually say, I kind of noticed this bluish discoloration underneath the skin, and they're not real sure what it is. But then you put ultrasound on it, or you do an MR, and you see these tangles of vessels underneath the skin, and that's a venous malformation. These are also amenable to treatment by interventional radiology, and we do a lot of this. So an arteriovenous malformation is an abnormal connection between an artery and a vein with a central nidus. And on this MR, this is what you would see here. You have your arterial and your venous areas that you see in this abnormal conglomeration of abnormal vessels. And then on the hand, you see it here. We don't like to treat these. They're more difficult, but they can be treated if you need to. That's because of bleeding. I had a little baby, a 20-day-old baby in fellowship that had a big arteriovenous malformation on her thigh, and it had eroded through the skin, and we treated her just because she was bleeding so much, and they didn't feel like a surgery would be very easy to do, and she did very well. And then the last simple connection is an arteriovenous fistula, which is a direct connection between an artery and a vein. And so on this DSA image, you can see the arteries of the leg, and then you see early filling of the veins, and that tells you that you have a direct connection between the artery and vein. Usually we think about these as iatrogenic from a cardiac cath or something like that, where you get a connection between the common femoral artery and vein, but they can happen due to any sort of trauma. I had a kid in fellowship that had a direct AV fistula in his wrist, and it looked like he had a dialysis fistula, and he got it from jumping on a trampoline. And so we were able, and surgery was not an option because there were so many small connections between the artery and vein that he needed intervention, embolization. These can be congenital as well, and these children can present with high output cardiac failure. So anytime you see some sort of abnormal communication, think of that. So we'll talk about combined vascular malformations. As I said, it can be a mixture of any of the above mentioned malformations. And the most common is a lymphatic and venous malformation, as you can see here in this arm and in the ankle. These are low flow lesions. They have abnormal venous and lymphatic channels and are also very amenable to sclerotherapy or embolization by interventional radiology. So there's lots of classifications for the people that talk about vascular malformations, but as they pertain to interventional radiology, you've got those that we treat and those that we don't really want to treat unless there's a really good reason. So like I said, we treat the simple venous or simple lymphatic malformations and can do a great job with those. We can also treat the combined vascular malformations. Those that we really don't like to treat are the borderline or malignant malformations, of course. We can prior to surgical intervention to control blood loss if we need to. And we also don't like to treat high flow arteriovenous malformations because those can be very difficult to treat. So treatment of vascular malformations in general. If you have a kid that just has a cosmetic problem and nobody is not ready for intervention, you can treat them with medical management with propranolol. I've read about using agents like, sort of like Avastin, angiogenesis, drugs to try and control these lesions. And then your next step is sclerotherapy. This is the kind of the least invasive type treatment, or they can be surgically removed. There's a little bit about radiofrequency ablation, but sclerotherapy and surgical therapy is the mainstays of treatment. So this is what I'm interested in. This is kind of what business I would like to grow here. So when you want a patient to have sclerotherapy, you're going to refer them to pediatric interventional radiology with current imaging, be it an ultrasound or MR, something like that. And then they'll come for a visit in clinic, and we'll get a real-time ultrasound there and kind of look at it ourselves, make sure that it's something that we think that we can do. They'll either get sedation with the pediatric sedation team or they'll have general anesthesia. It kind of depends on where you're practicing as to what you do. I think we have a great ped sedation team here, and so that would be sufficient. Then you're going to use ultrasound guidance to get access to the lesion. You're going to perform a venogram to ensure that there's no communication with the adjacent vasculature of the lesion. You aspirate as much of the cyst as you possibly can, and then you inject the volume, 60% of the volume of the cyst with Sotradecol, which is a detergent that kills the lining of the cyst, the epithelial cells. You'll allow 15 minutes of dwell time for the solution, and then you'll aspirate the contents of the cyst. And then you apply a pressure dressing while the patient's here for the next 2 to 3 hours to try and oppose the walls of the cyst together. And that will sclerose the edges of the cyst together, and the idea is that it doesn't fill up with the lymphatic fluid or blood that it did previously. And then the patient can go home the same day. They'll take antibiotics and they'll take ibuprofen for the next, as they need to, for the next 10 days, and generally don't have a problem. Things that you need to watch out for, they can get some redness underneath where you put the sclerosing agent in. But generally kids tolerate this very, very well. They'll follow up with us with an ultrasound and a clinical exam in 6 weeks. And if they need retreatment or additional treatment, we can do that at that time. So these are some of my cases from fellowship. This is a 6-year-old little girl that had a lymphatic malformation on the side of her face. So this is her ultrasound from clinic. You can see it's a simple lymphatic malformation. She does have some debris. So we brought her back and we did a venogram first. And you can see this is how the malformation feels. And you don't see any communication with the adjacent vasculature, which tells you that you're safe. And so then this is what it looks like when you inject the sclerosant into the cyst. It's air bubbles. You can see where you're going. You can see that you filled the whole cyst and that, all of the cells lining the cyst are going to be affected. And then this is our needle here, and we're aspirating the contents of the cyst. And then we put a pressure dressing on after we're done. And then this is her before and after. She is not as striking a difference as some of them are, but she had a really great outcome, and her family was very happy. So this is my favorite little guy. His parents have 7 adopted children. He is from China, and he was in an orphanage just because of this vascular malformation. And so his parents adopted him and brought him to Alabama, and he came to see us. So he has a very complex lesion, as you can see, with multiple cysts. This is still lymphatic malformation, but on the CT here you can see that this is a large multiloculated cystic lesion that's displacing his vessels kind of anteriorly in his muscles as well. And so it dives down into below his chest muscles. As you can see here, another very complicated cystic malformation. These children will always require more than one session for therapy, but they tend to do very well too. So this is our venogram, again showing no connection to the adjacent structures. This is another way that you can treat it. This is a drain. It's a 6 French, just a drain that you would use for any abscess. And then you can inject your Sotradecol. We actually used ethanol in this patient as well, just to try and use a different agent to try and sclerose the cyst even better. But ethanol we shy away from because it can cause some discoloration of the skin. But this child ended up having 3 drains into each of these large cysts. And he came back every 2 days, over a week, and his drains were left to JP bulbs to try and get as much of the fluid out as possible. And he did great. This is more of the internal contents of the cyst that we saw during our treatment. And again, multiloculated cystic lesion with a little bit of internal vascularity. And this is his after. This is after 2 sessions, which is a dramatic difference from before. He still needs more therapy and will still come back for more, and hopefully we can get this better. Sometimes these kids will have a fatty component to the lesion as well that can be removed later if it needs to be, but they do really well. As you can see, this is much flatter than it was before, but he's my favorite little guy here. We'll always remember. So that's the sclerotherapy part of it that I wanted to talk about. There's a lot of pediatric interventions that we can do. Anything that you can do on an adult, we can do on a child pretty much. Mostly children are, feeding, enteral feeding type things. This is a gastrostomy. This is a Mickey button. And I know here and everywhere about usually the smaller kids, these are placed surgically. We can check them, we can change them out, we can exchange them over a wire, we can declog them if they're clogged. So there's a lot of things that we can do to help you in patients that have gastrostomies. And in larger children, we can place them primarily as well. A lot of children need a gastrojejunostomy as well, and this again is a Mickey button for a gastrojejunostomy. It has a gastric port and a jejunal port that they use for feeding. We do a lot of this, conversion of a gastrostomy to a gastrojejunostomy. So this is your Mickey button that you have here, and it is in the stomach. And then to convert it to a gastrojejunostomy, you negotiate through the pylorus and into the duodenum. And then you'll negotiate this bowel, and you'll leave the end of the catheter just past the ligament of Treitz into the proximal jejunum. And that helps kids with aspiration mostly. and then you still have enough of the jejunum to absorb their nutrients. So this is a popular procedure that we do in children. We can do any sort of venous access that you need, any sort of central line. We can do a PIC. We can do a small bore tunneled catheter in patients that have poor renal function. We can do dialysis access, and we can put in ports primarily as well. And save children from having to go to the OR and have general anesthesia just for a port that we can put it in 15 minutes. It's a great thing that we can offer. We can do any of your biopsies, which I know that we already do. Ultrasound or CT guided biopsies, of liver, thyroid, kidney, any kind of image guided biopsy we can offer. And again, this is kind of one of the more common things that we do, abscess drainages for children. We can also do end-of-life management for your cancer patients with tunneled ascites drains or a tunneled pleural effusion drain, and that could be very helpful as well. We, again, do diagnostic angiography in children too. Am I going to pick on a radiology resident? Coulter. What is this?
It looks like multiple pulmonary aneurysms.
Kidney. Sorry, I didn't give you the whole kidney. It's hard. Kidney. It's polyarteritis nodosa, which is a vasculitis that is really difficult to diagnose with anything other than diagnostic angiography. It's hard to see those little aneurysms with CT or ultrasound. So this is another, this is a venogram that we can offer. Tom, you called out Coulter, so it's your term now. It is? Why would this is a kid, so why would that patient have the? What runs here? Okay, so what would be here?
It's crossing the
Right. May-Thurner. So this is the May-Thurner syndrome, where you have the aorta would run here, and then you would have the right common iliac artery that crosses over the left iliac vein, and you can cause thrombosis of the left iliac vein. We saw a bunch of these in fellowship for some reason, and we would do thrombolysis of the iliac and then stent the common iliac open. We can do a percutaneous nephrostomy in children. I think that you have excellent pediatric urology here, so you might not have a need for it. But to do a percutaneous nephrostomy, you enter the skin, you go through the calyx of the kidney, and you park a catheter in the collecting system, and then that drains the urine. You can, drain an obstructed system, or you can divert urine until a lesion in the bladder or a distal ureter heals. We can do inferior vena cava filter placements in larger children. Currently, this is my favorite filter. I don't have any affiliation with these people, but it's a great filter, and it can be placed in children. And then we can do percutaneous transhepatic cholangiography. Mostly this is going to be for your older patients with primary sclerosing cholangitis, or you see it mostly in children with transplant, which I know you don't see a lot of here, but it could happen. We can stent open the common bile duct if needed with a percutaneous transhepatic cholangiography with a biliary drain placement. And we can do tumor ablation. And you can't really see it very well here, but this is an osteoid osteoma. And you can use radiofrequency ablation to get rid of these tumors, and these patients do very well after. So we do a whole lot more. Interventional radiology we do a lot of things, and that is not an all-inclusive lecture. But I just wanted to come and tell you that we're here. We want to help you. My goal would be to eventually in life be only pediatric interventional radiology, and I'm hoping that you guys can help me with that. And so hope that you send people to me. So how do I get my patient a procedure? We're tentatively planning maybe a half day of clinic per month for these outpatient vascular malformation treatments for them to come to clinic. And then I'll have one procedure day per month here at LSU, just to start out with. And you can contact the outpatient interventional radiology scheduling person to get in touch with us and figure out how we do that. That's all I have. It was short. Can I answer any questions? Right. Right.
When a patient that is an inpatient.
An inpatient, they would stay overnight, or?
No, a patient is in the house.
Okay, well, gastrostomy, those are usually inpatient. Abscesses are usually inpatient. Just about anything but sclerotherapy is inpatient generally for children.
So if the pediatricians had one of those, they contact our resident on interventional?
Yes, and they could get you.
Would contact you?
No, yes, they could.
And they would contact you and send you pictures or whatever you needed it?
Right.
And if it was an emergency, you would be able to come over?
That's what we're hoping to work out with the VA.
And there are a lot of things that we need to work out because, despite they're in the same place, institutionally are different entities and there are these issues that the flexibility is something we should address. I think we will allow this. It's something that is really the benefit of the community.
Do the pediatricians have any venous malformations, lymphatic malformations, or any interventions right now? That you guys know about?
Get a lymphatic malformation.
I don't remember the name. I can look back at my call. So, pediatricians, please take advantage of an expert in this, okay?
Yes, which looks as well.
Yes. Yeah, we did a lot of that bronchial artery embolization for hemoptysis. That's a good one. Mm-hmm. 12 or 13 usually is what we saw. That's when they start getting very severe, changes. The ones that are very sick get to be about 12 or 13 and then need, a bronchial artery embolization for hemoptysis. That would be an inpatient case, of course. No. Hello here.